Do you think that so there's the
Yeah.
science aspect, and you know how people talk about like you need to believe something to make it true,
Hmm.
right? When it comes to treating patients, so this is science and biology and some force of life because there's life within that body.
Right.
And when the body dies, the life is gone. It's a dead body. Do you think that there's some aspect of if you, as the oncologist, and your entire supporting staff and every other person in the medical arena that this patient encounters, if every one of them really believes and really puts that this person can live longer, the treatment will work, and they put every aspect, they do the work with more care, and does that belief aspect, can it end up making a dent within the statistics and change the statistics?
Certainly, when there's a lot more hands-on care, like with clinical trial patients, they do tend to perform better than, the average patient that we just see in clinic that may or may not be eligible for that trial.
What's clinical trial?
So when clinical trials are done, these are testing different medicines, testing different ways to treating, and so basically, in a randomized fashion, patients will either be assigned to the standard of care arm or to the experimental arm, testing a new drug or a new way to treat. These patients that are in clinical trials are heavily pre-screened, have to have very minimal medical issues, be able to and basically be evaluated to see if the trial doctor can think they can complete the treatment. And in reality, the average patient we see probably never fits that clinical. There's a good proportion of patients that we see that don't fit, that would not be eligible for that trial, but we have to use that trial to treat them because that's kind of that'll be our new standard of care.
Oh,
And so,
but since they're not selected randomly enough, that's why they have better
right,
results.
right, right.
Okay.
So the average clinic patient is probably not going to do as well as a clinical trial patient who's screened to be a better performer.
Yeah.
And so there is bias in that, and we're aware of that, and we always look to see, this patient is on 6 liters of oxygen, can barely walk up the flight of stairs, is on the couch all day. She's likely going to die of her lung disease. Do we really want to give her this standard of care treatment, even though it's indicated by the trial? And so we have to make those decisions every day to treat or not treat. That sometimes the treatment is worse than not treating.
Mm-hmm.
And so, you really only learn these things by running your own clinic or being in the clinic and taking responsibility. There's a lot of things in training that I think are lost, and that's basically we're spending so much time just trying to learn how to treat and learn why we have to treat, that there's so many other aspects of clinical management that are in play, like what's the patient's social situation, can they get to treatment, do they have transportation issues, are they taking, like I have had patients that say I can't get any treatment right now, my mother is dying, my wife is dying, I have to spend a lot of time taking care of her and I can't just come and do these treatments. And it's like, what do you say to that? You're like, well, if you don't get the treatment, you don't say if you don't get the treatment you're going to die, but you have to be understanding of that situation. And sometimes it works out, and sometimes the cancer does get worse because they haven't gotten treatment. These are issues that on paper in clinic prep everything looks great. You go in and see them and talk to them, and then you see all these different aspects that they have to deal with, and then I can treat anybody on paper. But once you've seen them and evaluate them, then you can say, okay, I understand the difficulties in the situation. Let's see how we can get everything coordinated.